Welcome back to Brain Pods. Thank you for joining us. I am here with Dr. Conrad Iber. Say hi, Con.
Good morning or afternoon.
Con has been so kind as to invite me over to his house where we're filming Brain Pods number 4 to talk about sleep. Dr. Iber is a pulmonologist and a mentor and friend of mine going back many years, almost 20 years now, Con, if you can stand that.
Yeah.
I love this story. How you got? Would you mind just kind of telling a little of the story on how you ended up as a pulmonologist interested in sleep, in particular brain control of sleep, respiratory?
So we were interested. I was working with a physiologist at that time, and we were interested in what starts and stops breathing.
Oh.
And it got very complicated in studying people who were awake. And so it seemed that the only way we were going to solve this problem was to take away all the behavioral activity that normally accompanies our speech and all of our activity and monitor people during sleep, which meant that I had to go down the hallway and learn how to put on EEG leads and do sleep studies.
which were very new at the time, right? That was, what, 1980,
This was back in 1937. No. Yeah, it was back in 1980. The first sleep centers were in the mid to late 70s, so this was one of the first 5.
That had up at HCMC.
At HCMC at that time. The year before that, when I started some of these experiments, were the days in which sleep centers didn't even exist. At the University of Wisconsin, we didn't have a sleep center. So it was neurology, pulmonary-based, essentially clinical work. And it evolved kind of quickly. For instance, I learned how to do the physiologic studies, and subsequent to that, and doing these studies at night on breathing, I started to be approached about doing clinical care because we could suddenly do a test that diagnosed the problem.
Right.
And for a lot of people in the field at that time, that's how the field progressed, as we were actually solving clinical problems.
So sleep is a young field in comparison to most other specialties and subspecialties of medicine, and it is uniquely multidisciplinary in that neurologists, pulmonologists, pediatricians, psychiatrists, otolaryngologists. I'm missing a few. Anesthesia as
Family
well.
medicine.
Family medicine. Cardiology. If you work with an organ system that fluctuates during sleep, which means all of them, you can have an interest in sleep as well. So, well, we better get started. We have a lot of material to go through, and you and I are notoriously at talking long, and especially if we get together. So let's get started. So let's just start in the first place of why sleep is important. Here is one reason. A classic fall asleep motor vehicle accident. You've seen that video several times before. When I look at that, Con, I think of someone who, like a lot of us, admittedly has dozed off for a moment while sleeping, but had tragic results in this case. 1 out of every 24 drivers admits in the last month to have actually dozed off, nodded off a little bit while driving. Can be life-threatening to the individual and the general public. There's often this slow drift, and there will be a collision with a guardrail or another car, usually without any evidence of brakes being applied. Any other thoughts on motor vehicle accidents? And
one of the most common causes of death in adolescence, because 2/3 of adolescents don't get sufficient sleep. So there are some parts of our population that suffer tremendously from this. It's also, I think, an indication of our poor judgment, because who would be driving a car and fall asleep at the wheel other than somebody who no longer recognizes that they're impaired?
Yep. And it's a reversible cause of injury, and so we're excited to either through new technology is actually hopefully within a generation putting most of these accidents behind us. So that's just the obvious answer as to why sleep is important. But what we're going to talk about a little bit is sleep physiology. Sleep is not a homogeneous state. We cycle through states and stages of sleep. We're going to talk about sleep disorders, which are nicely divided up into insomnias, can't fall asleep, hypersomnias, means you're too sleepy, as well as parasomnias. Some odd behavior is happening at night. And throughout all of this, I will ask you to think of sleep as part of a larger process, your body's 24-hour circadian rhythm. Because many people come in with a sleep complaint when the actual problem is an underlying misalignment or disorder of their body's circadian rhythm. Very important when you first start thinking about sleep. It's important to remove the conception that sleep is a deeply homogeneous state of unconsciousness. We are cycling through sleep throughout the course of the night, and what this is called a hypnogram, which is about 8 hours here on the x-axis, and on the y-axis is the different stages of sleep. So we start the night awake, of course, and then we fall asleep into deeper and deeper stages of sleep, and this N1, N2, N3, that's the stages of non-REM sleep. And then we cycle back up to this very fascinating state, which we'll get to again in a moment, which is REM sleep, which stands for rapid eye movement sleep. It is a fairly shallow stage of sleep, REM sleep is. It's when we dream most vividly. Our bodies, our skeletal muscles are paralyzed during this. And the other clinically relevant aspect of this to think about is recognize that it's perfectly normal to have an awakening intermittently throughout the course of the night. You have all been doing this throughout your lives, whether or not you recall it or not. But this can be frustrating to patients who may not understand that it's perfectly okay to wake up a few times throughout the course of the night. As we go through these different stages and states of sleep, different things are happening in our brain. If you just to walk us through it here one time. So as you start going down into the lightest stage of non-REM sleep is N1. If we awoke you from N1 sleep, you probably you'd be convinced you hadn't quite fallen asleep yet. Oftentimes there's a slight drop in your body's core body temperature. So if you feel a little chilled, that might be a good indication that you fell into N1 sleep. N2 sleep is the intermediate stage of non-REM sleep. Interestingly, it probably because it's a state of transition between light wakefulness and deep sleep, it's often where we see the greatest amount of non-REM sleep pathology, whether or not that's obstructive sleep apnea or seizures. And N3 sleep is the deep state of sleep when you wake up the next morning feeling refreshed. It's probably because you got a decent amount of N3 sleep. REM sleep stands for rapid eye movements. It is a fascinating state. The brain activity is very similar to wakefulness. We have vivid dreams, but we, under normal circumstances, do not act out these vivid dreams because we have skeletal muscle paralysis. It's interesting for a variety of reasons. It appears to be critical for brain development because children have just a tremendous amount of REM sleep, and that slowly goes down as they go through development. It's also a relatively light stage of sleep, so you can awaken somebody from REM sleep, or you can be awoken yourself, whether or not that's from a phone call, a text, or a page from the hospital, and you can tell which stage of sleep you're coming from. Con, you've had many nights of being woken in the middle of the night with calls. Any thoughts on knowing whether or not you were in different stages of sleep as you were being paged?
Well, yeah, I think that if you waken in a confusional state, and I think most of us will have that experience if we've been sleep deprived,
Sure.
then you're probably, geographically our brain, it's not like a switch. I think that's another point here. We have geographic areas which may be not fully awake, and so we can't, sometimes in one case,
Yep.
I couldn't speak for just a few seconds until my motor strip had...
And language
and
center.
language
Yep. Yep.
had started. So I think it's important, REM sleep, it's a very active stage of sleep. Our brain is activated, maybe not the frontal cortex,
Yep.
but the primitive areas. And so it certainly is physiologically much closer to wakefulness, except for the fact that we're paralyzed and we don't control our body temperature very well.
Yeah, right. So that's in REM sleep we become, for a short period of time, ectothermic. We for all practical purposes stop generating our own internal body temperature, which is at least one of the very important reasons why we sleep under blankets. So, in case you were ever wondering why that was. So for those of you who have cats, based on what we've talked about already with the sleep cycle, you can stage your cat's sleep. The cat on the left here is in non-REM sleep, and the cat on the right is in REM sleep. And the reason why we know that is this cat is atonic. They are unable to maintain the axial posture of a cat in non-REM sleep because of the normal REM sleep paralysis. There's a lot of very exciting things happening in the world of sleep and neuroscience and understanding why it is that we sleep and what is happening at different stages of sleep. Let me just touch on a couple of very exciting ones, one of which is the concept of synaptic homeostasis. So the brain is composed of 100 billion neurons, probably about, give or take, 100 trillion synapses. And as you go throughout your day and your neurons talk to each other, they get stronger and stronger through a process called long-term potentiation. A nice phrase I like to use for this is neurons that fire together wire together. The problem is that our skulls are a limited amount of space, and there's only so many synapses you can put together before you start running out of space, and you are unable to generate appropriate signals because of all the synaptic noise. And our brain has come up with a very clever way of dealing with this by synaptic depotentiation. So the breaking, the pruning of these synapses when we're in deep, slow-wave non-REM sleep. This results in energy and space savings. And because of the improved signal-to-noise ratio, you end up with memory consolidation and learning.
I was just going to make a brief comment about that. So one might be concerned about that process. You'd want that done right.
Yes.
And
you could go awry.
And it's fortunate that the process includes an emotional labeling component to it. So if there is a valence associated with that connection, then it's going to be potentiated, and the ones that are going to be pruned are the ones that are not important. So if you were told that this question was going to be on the exam tomorrow, then you would remember that one.
Because there's an emotional charge associated with it.
Yeah.
Fear, for example, is and we're going to get to that. It appears that much of what Dr. Iber is talking about, this emotional limbic consolidation of memories, really seems to be augmented during REM sleep, which has some fascinating implications of what does that say about dreams, which we know are emotionally charged and full of memories, as well as a variety of imagined experiences.
I might just make a quick comment.
Yep.
Be careful here not to take this too But when we talked about REM, we talked about muscle paralysis.
Yep.
And it might be really important to know in some situations pathology where that's really important. For instance, our breathing muscles. Many of the ones that we use for assistance are knocked out in REM, whereas the diaphragm, fortunately, is preserved.
Right, but all those accessory muscles of respiration.
So people with lung disease are going to have more of a problem in REM.
Which we will get to.
All right.
All right, so continuing along with what else is happening during non-REM sleep. I remember I was with Dr. Iber one Friday morning when we read about this in Science about 5 years ago. A few elegant experiments demonstrated, as have some follow-up studies, that glymphatic clearance What is the glymphatic system? So while the brain does not have a lymphatic system, there are no lymph nodes in the brain, nor are there lymphatic channels. What you do have however, are you have astrocytes. Astrocytes are the tan. I'm not really great with colors, Con. Would you say tan, brown?
Mm-hmm.
These brownish cells here are astrocytes, and they create these they have these foot pores, channels that are around veins and venules. And they create these channels that form the glymphatic system because glia include astrocytes. And they form these channels which later ultimately drain into the lymphatic system once they leave the CNS. Yeah, but during the course of the day, you still need to have some process that washes away the metabolic byproducts that all of our cells have. And so what has been demonstrated in a few elegant experiments is that the neuronal cells, possibly the glial cells as well, but the neuronal cells, which are the blue cells here, actually shrink, which is a little mind-blowing, isn't it? They shrink by about 20-30% at night, which opens up extracellular spaces so that the CSF can wash through and clear out various metabolic byproducts. And there's an animation here. I'll just ask you to pay attention to this part of the slide right here. What you're going to see is you're going to see these waves of cerebral spinal fluid pulsing from the arterial bed, wash all of these little various waste products out through the glymphatic channels and out of the CNS. So here comes the CSF pulse waves, and it just kind of nicely clears everything out. Interestingly enough, one of the products that has been studied the most here is insoluble beta amyloid, which of course builds up in Alzheimer's disease as well as other traumatic brain injuries and concussions, raising some very interesting questions as to whether or not at least part of the pathology cascade of these conditions, in particular Alzheimer's disease, may be related to a failure of clearing CNS toxins during sleep.
So this is a specific sleep-related activity.
Right. Right.
So
well, there's
important point.
Yeah. There's the glymphatic system is there when we are awake, but it seems to there's much more of it appears to get flushed out during sleep, and probably again during non-REM sleep. Okay.
Even in normal individuals with sleep disruption, there's an increase in amyloid and tau. And so one of the concerns is that insufficient sleep may carry a burden. Of course, we don't have long-term data on this.
Right. We do know if you're 50 years old and you're not sleeping well, you are at higher risk of ultimately developing a neurodegenerative condition, as well as a variety of other mood and anxiety disorders. Just a couple practical ways to think about sleep. There's the popular culture and the scientific literature is full of anecdotes of people who have come up with various brilliant insights either after a night of sleep or maybe after a napping. Just a couple of examples here. Cacula in the mid 19th century knew that benzene was composed of 6 carbon atoms and 6 hydrogen atoms and a certain number of double bonds. But at that point we didn't know about aromatic or ringed organic compounds, so it was uncertain exactly. And he was working on this question of what is the organic structure of benzene, and he indicated that he was working on this and working on it. He dozed off and he took a nap, and he had a dream of a snake eating its own tail, right? And he woke up and he's like, oh my goodness, benzene it's a ring structure. Paul McCartney there indicated that the most popular song of the 20th century, as voted by Rolling Stone magazine, which is the Beatles' Yesterday, came to him during a dream. A variety of other examples over here on the right, including the principle of chemical neurotransmission, Mendelev's periodic table. I would just point out, if you're working on various problems, sometimes the best thing you can do is actually get a good night's sleep or take a nap on it.
Performance on tests is better in the morning.
Yep.
Problem solving.
After a good night.
After good
After a
night's
good night's sleep.
Not with cramming.
Not with cramming and staying up all night long.
Performance on tests and problem solving. And one of the theories is the assimilation that's going on in the brain, which is the information's been transported, and now the brain has an opportunity to assimilate and to integrate it into the rest of the known conceptual.
We also we tend to have a better perspective of things in the morning, right? It's the phrase is sometimes given to newlywed couples: "Never go to bed angry." I think the best thing you could possibly do is go to bed angry, get a good night's sleep, and then you'll have a better perspective on things in the morning.
Sleep on it.
My wife doesn't agree with that. All right. Well, moving on to REM sleep. So just a couple of concepts to know about REM sleep is that we have the majority of our REM sleep is when we are children. There's a high level of REM sleep followed by a slow decrease into adulthood. This slide basically shows from birth to death, and based on prenatal studies earlier, it seems that we have much more REM sleep, or the whatever the state is that leads into REM sleep is far more pronounced at birth, and then slowly becomes less and less pronounced, replaced mainly by wakefulness. And non-REM sleep stays pretty even until adolescence, and then that drops down as well. This slide also illustrates something important, which is that children just need more sleep. Even teenagers, adolescents still need more sleep than adults, and it isn't until we get well into our 20s that our sleep need really starts dropping. Starts dropping off to what we consider kind of a normal 7 to 8 hours requirement for adults.
Good to remember that children are going through an incredible amount of remodeling, and one might even think of this as a very vulnerable time period for the brain. So, and it's understandable that there would be a larger dose of sleep required and larger amounts of REM under these circumstances, as well as developing connections with the body, which is part of the process that's going on.
Mm-hmm. All right, now we're just gonna jump right now into sleep disorders. So sleep disorders, to state the obvious: common, distressing, numerous comorbidities, early mortality, not just fall asleep motor vehicle accidents, but cardiovascular disease, obesity, mood disorders, substance abuse, malignancy. And unfortunately, tragically, we live in a culture where sleep has essentially been thought to be disposable, or at the very least can be put off until a more convenient time, which never arrives.
I think the attitude is that sleep is somewhat cosmetic, that it's not really needed. I think we're making a case in the first part here that something quite incredible is going on in the brain. If 20% of the synapses are undergoing remodeling at night, if there's a profound reconnection that's going on in children, then obviously this sleep, and if there's a clearance of neurotoxins, then obviously sleep is a biological imperative.
Well said. So, in many ways, taking care of sleep disorders is fairly straightforward. There's really only three main reasons why people come in and see us. At least this is the way I think about it. Either they can't sleep, or they're too sleepy, and in this category I include, and we'll talk about sleep disordered breathing, because that is often, although not universally, how people with sleep disordered breathing present, or something unusual, bizarre, weird is happening at night. So, amongst people who can't sleep, I think the three syndromes that you want to think about when you're taking care of someone with this extremely common problem, this is the most common reason why people come and see us, think of three conditions: either psychophysiological insomnia, restless leg syndrome, and circadian delay. And the patient themselves often doesn't know which category they would fall into, even if they knew what these categories were. And we're going to go ahead and review them right now. So we'll get to in a second, I mean. So just talk about how common this is. So 30% of American adults will describe at least occasionally some difficulty falling asleep. And a third of them, so 10% of the total population, indicate that they have daytime dysfunction emanating from their difficulty falling asleep or staying asleep at night. This results in 5.5 million office visits. And over the course that we've been practicing this con, the employment of sedative hypnotic medications has skyrocketed in parallel, really, with the overuse of opioid pain medication. There's also been an I think we would describe in many cases an overuse of sedative hypnotic medications, and so we have from 1999 we had about 5 million prescriptions, and in 2010, the most recent year we have data, we had 21 million. Over half of these here in 2010 were not on one but two or more sedatives, and 25% of them were also on an opioid as well. So that's a pretty hefty dose of sedation.
I might just
comment
if that's
please.
okay.
Oh yeah, that'd be great.
I think first of all, regarding the sleep disorders, there's sort of one population again that we tend to forget about, which is shift workers.
Yep.
Can't sleep because their schedules. Even high school students, 85% of high schools are set at a time that's probably too early for their circadian rhythm. So sometimes it's the employment, 12 million people in this country, or the schedule itself, which contributes to the problem. And it's interesting that we're using sedatives to the extent that we are when the National Health Service in England and the American College of Physicians in this country do not recommend the use of sedatives for insomnia as initial therapy. So obviously there's a little disconnect sometimes between what we're doing and perhaps what's the right thing to do.
Shift work is extremely difficult, and there's incredible there's interpersonal variation. So and you'll see this in a residency when they do overnight shift work. Some residents bounce back from it very quickly. Others really suffer from it quite a bit. All right, so let's talk about psychophysiological insomnia. So this is the inability to initiate and maintain adequate sleep, and I think here's the most important piece of this clinically, at any time on the clock. So they go to bed at 10 o'clock at night, 11 o'clock at night. They struggle to fall asleep. Maybe they doze off a little bit, but then they wake up a couple hours later. When the alarm clock goes off at 5, 6 o'clock in the morning, they're tired and they get out of bed, but they really couldn't sleep much longer even if you asked them to. Their brain is just in a state of hypervigilance 24 hours a day. This is a conditioned response. There's all of us, if any of us are put through the right amount of stress, we'll all have times in our life where we're not sleeping well. That's to be expected. That's normal. The problem is once that stress goes away, do you now have a conditioned response where you're lying in bed, you're not able to fall asleep, and no one ever laid awake in a dark room and stared at the ceiling trying to sleep, struggling to sleep, and thought about how great their life was. They end up ruminating on whether or not you mean to or you don't mean to. They end up ruminating on things to do the next day, patients to see, bills that need to be paid, relationship challenges.
Or even why we can't sleep.
Or even why, right? What is wrong with me? I mean, there's something wrong with me. So the sleeping pills are often prescribed in these cases. This is the condition, the psychophysiological insomnia, really was the condition for which these agents were developed. These are the zolpidems. These are the azopiclones. These are derivatives of benzodiazepines, which have also been historically used for sleeping. They do have concerning adverse side effects, including morning sedation. They can lead to depression. They can contribute to sleep disorder breathing. A couple things to note, that they really only modestly improve objective sleep efficiency. So if you had a EEG on someone who was measuring EEG on someone's brain that was measuring their brain waves, and you put them on these agents, the amount of sleep you really get from these per night is pretty modest. I think it's 20 minutes, 25 minutes compared to a placebo. However, their subjective sleep efficiency, right, that goes through the roof. They feel like it knocked them out. They feel like their sleep efficiency approach nearly 100% of their time in bed.
Is that because they don't remember awakening?
Right. Yeah. So these are that's thank you. Yeah. These are mainly amnestic agents, which is not to say that they don't have utility. Both Dr. Iber and myself will occasionally prescribe these, but they are not our first choice. They do have concerning side effects from them. One of which is sleepwalking. And sleep-related eating and complex amnestic behaviors that can happen on these medications at night. Yeah.
And as you pointed out, some people take a second dose. Maybe a third of the population who take these agents will take a second dose, and that might be just in time for their morning drive into work.
Oh, yeah, right. Because in their, from their perspective, they're putting a lot of pressure on their brains to fall asleep, which is not soporific. To try to lay there and try to force yourself to fall asleep. So the hands down best therapy for physiological insomnia has really been effectively demonstrated to be cognitive behavioral therapy for insomnia. And what is cognitive behavioral therapy? If you go back and recognize that psychophysiological insomnia is a conditioned response, right? They have an adverse subconscious response, just like Pavlov's dog, to lying in bed to a state of hypervigilance. You essentially condition them. You use behavioral and cognitive condition to reverse that process. So you don't let them go to bed unless they are tired and sleepy and essentially dozing off. And then if they're in bed and they're not sleeping, they need to get out of bed. They need to get out of the environment, and they're not allowed to sleep outside their bedroom. Which sounds like three simple rules, but they are extremely difficult in practice at 2 o'clock in the morning when you got a big meeting going on the next morning to follow through on it. But if you do, if you have a motivated, insightful patient, it really works well.
Very important to have regularity of these things. So we reinforce the strength of the sleep clock by regularity. One of the mistakes people often make is if they've had a bad night's sleep, they go to bed maybe an hour, half hour early.
Yep.
Which is a bit of a problem because your sleep clock is not set at that time. It would be like if your bedtime is at 10, you decide to go to sleep at 8 o'clock. It doesn't work. And so people get into secondary habits which are defeating.
But they hope, right? They hope, they hope they can fall asleep. So I think, and many of the people we're talking to right now, at some point in your life, you are going to have trouble falling asleep. And we are coming to you from the future, and we are telling you, stop trying. Your brain will let you fall asleep, but you have to let it fall asleep. You cannot trick your brain into falling asleep. It's going to come or it's not going to come. All right. So moving on, let's talk a little bit about restless leg syndrome. So restless leg syndrome is characterized by a clinical quadriad of discomfort, and it's primarily discomfort in the lower extremities, but people can have full body, they can have torso, they can have abdominal, they can have upper extremity restlessness, and this is more than just pain. This discomfort compels movement. People really feel an urge to move, and movement relieves the discomfort. However, it only relieves it usually for maybe a minute or two, or sometimes if it's severe, only for a second or two. This has a diurnal pattern, so it worsens at night, right when we're wanting to go to bed, right when our bodies are trying to calm down a little bit, and thus interferes with our ability to fall asleep. People with restless leg syndrome, at least the ones who come to see us, often don't recognize they have restless leg syndrome. All they describe is I have insomnia, I have trouble falling asleep. Please give me something to knock me out. And if you'd end up giving them one of the sedative hypnotics we talked about before, which are mainly amnestic agents, these are the patients you're often going to induce a sleepwalking or sleep eating type behavior. Who gets restless leg syndrome? Almost every neurological disease, whether or not it's a stroke or spinal cord disease, neuropathy, multiple sclerosis, they often have an increased incidence of restless leg syndrome. if you're looking at otherwise healthy population of who gets restless leg syndrome, you're really talking about iron deficiency. Um, so this is just incredibly common in otherwise healthy premenstrual women, um, uh, pro- profoundly so during pregnancy because they're already relatively iron deficient, and then the massive hemoglobin expansion just sucks up all the available iron, and then results in a deficiency of brain dopamine. And why is that? Well, here is the metabolic pathway by which we convert tyrosine into dopamine. The rate limiting step is tyrosine hydroxylase, and iron is a cofactor. Um, what do we do to treat restless leg syndrome? Well, iron replacement. Unfortunately, iron replacement is tricky because the gut doesn't absorb iron particularly well, especially if you give it to people in a bolus. We get constipation, we get abdominal discomfort. And so individuals who are already iron deficient, sometimes it's quite challenging to replace it orally, but we do try. You can use IV iron infusion. That can be helpful. And then if this is not a case of iron deficient restless leg syndrome, or if you're just not able to resolve the iron deficiency, you can use medications. We tend to start with the alpha-2 delta ligands. These are the gabapentins and the pregabalins. Side effects of sedation, weight gain, depression. If those don't work, we often move on and try dopamine agonists, because again, this is a deficiency of the CNS neurotransmitter dopamine. And with those, we use pramipexole or ropinirole, and these agents were originally developed for the treatment of Parkinson's disease. People with restless leg syndrome do not have a strikingly elevated risk of going on to get Parkinson's disease. It's just a situation where the medications often work for different problems. The side effects of pramipexole and ropinirole are the dopamine side effects, so include nausea, emesis, headache, orthostasis. Concerningly, when you get to high doses of these agents, they tend to become less and less effective. 10, 15 years ago, pramipexole and ropinirole were a treatment of choice, right? That was usually our first line therapy. And we've come to realize, especially in young people who we're going to be taken care of for a long time, a few years, sometimes as little as months later, that 1 milligram of pramipexole doesn't work anymore. Now you need to give 1.5, and then you need to go higher than that. And very concerning side effects of these agents include impulsivity. So impulsive gambling, impulsive shopping, sexual behavior, those sorts of things. And then once you get to that point, you got to get them off the medication. And then finally, this is a situation where the only therapy that works are opioids, and Dr. Iber and I are strong believers in trying to minimize the employment in the use of opioids. A good therapy here is methadone, which has the benefit of being longer acting. It affects the mu receptor in particular, which seems to really knock down restlessness. And oftentimes you can take care of these patients with very low doses, 5-10 milligrams a couple times a day, which is much lower than we typically think when employing methadone for patients who have opioid dependency. Any other thoughts on the treatment of RLS, Con?
No, I think that's
you covered it. All right. So let's move on to the last one, which is, what is the most common cause of difficulty initiating sleep in medical students? You want to take a stab at this one, Con?
work.
Circadian delay, right? So this is a delay in our body's 24-hour clock. So all of the cells of your body have a 24-hour circadian rhythm. What they are doing at 2 o'clock in the afternoon is different from what they're doing at 8 o'clock in the morning. And our body gets its circadian cue of what time their body should be in sync with the environment, based primarily but not solely upon light, particularly light in the morning. So what does circadian delay look like? So they in many ways it looks quite similar to somebody with psychophysiological insomnia, right? They go to bed, they lie there, they can't fall asleep, they're extremely frustrated. But in contrast to people with psychophysiological insomnia, which we mentioned before, have trouble falling asleep at any time on the clock, ultimately, if you just wait long enough, these individuals will be able to fall asleep, whether or not it's midnight, 1, 2, 3, 4, 5 o'clock in the morning. Then they're out, and then they'd like to sleep until noon or 1 or 2 o'clock in the afternoon, or some variation thereof. And when that alarm clock goes off in the morning, they're hitting the snooze alarm several times. They're like, "You're kidding me! I just fell asleep. But you're telling me I have to wake up now."
So circadian delay is a normal developmental delay. And actually, if you're a medical student, you've been dealing with it for a long time, because that starts generally around puberty, around the age of 12.
Yep.
And high school students are impacted substantially. College students are impacted. And so by the time you got to medical school,
Yep.
you've got some experience with this, but then you also have some on-call duties and nighttime activities and studying,
Sure.
which contribute to the insufficient sleep. So at the same time, you got a lot of material to process, which means we want you to have the opportunity to have your brains optimized.
That's exactly right. So why does this happen? Well, it is a sensitivity to evening light exposure and a relative absence of morning light exposure. So the light from our computer screens, from televisions, from our telephones, all of this sends a signal through the ganglion cell layer in your retina to the suprachiasmatic nucleus, right? That is not an accident. That is suprachiasmatic, so right on top of the optic chiasm, very short pathway, which then is the master circadian pacemaker for all of the circadian rhythms in your body, and all of your cells and organs have a circadian rhythm. Your liver does, your skin does, kidneys, cardiac, pulmonary system. And when this is working well, the suprachiasmatic nucleus, like a master clock, just syncs all of them appropriately. When it's not working well, it could be delayed for what you want it to be. You could have various organ system clocks operating independently. It's an exciting area of research. We won't be able to get into it all, but it's fascinating. But for a circadian rhythm delay, the conventional problem is that we get way too much light. If you compare to 300 years ago, we have 3-4 orders of magnitude more light exposure in the evening. And yet, in addition to that, especially here in Minnesota, where we have a lack of morning sunlight for several months of the year, and even during the summertime, we often only get how much sunlight do we really get in the morning? Conversely, if you think about how we evolved as early hominids, with the sun coming up over that eastern horizon and setting over the west every single day, kind of resetting our circadian rhythm, we don't get that anymore. And so it's the combination of too much light in the evening, convincing our brains that the sun is still out, and lack of morning sunlight in the morning, convincing ourselves that our brains and bodies, that the sun is not up. So what do we do about this? This is not a disorder that requires pharmacological intervention. This is light box therapy. You use a 10,000 lux light box. This is the same sort of light box used for individuals with seasonal affective disorder. They're available over the counter. You don't look directly at them. You're careful in patients who have macular degeneration. But you just get, most of the studies say 120 minutes, but most people find that quite difficult to achieve. And you get that first thing in the morning. That's when the phase response is most profound, usually right when we're getting up in the morning. And then you can use melatonin. Melatonin is an over-the-counter vitamin supplement, at least in the United States. You don't need very much. Most of the bottles at the CVS and the Walgreens health food stores are 3 milligrams, 5 milligrams, 10 milligrams I've seen. You don't need that much. Get a 1 milligram tablet, cut it in half, and you take it about 4 hours before your desired sleep time. This is for people with a circadian rhythm delay. And so let's just say for a moment you have an individual who, if the whole world would let them, they'd go to bed at midnight or 1 o'clock in the morning, and they'd sleep until 8 or 9 o'clock in the morning. But they can't do that because they got to get up for their pulmonary clerkship con at 6 o'clock in the morning. So what you do is you use the light box for at about 6 o'clock in the morning, and then if you want to go to bed at about 10, you're taking melatonin about 6 o'clock in the evening. That is not an accident. Those 12 hours apart from each other. This is another way to think about this is your pin drop on Google Maps is falling down in the wrong time zone. And so we're just trying to remove your circadian rhythm so you're in the right part of the planet.
So
Any
this
other
drug,
thoughts? Yeah.
the melatonin, is not a drug to induce sleep.
Yep,
Just
that's right.
kind of reiterate it.
Yep.
It's really, and it's not given in even a dose. It's given a very small dose so that it won't cause you to be sleepy as much as adjust your sleep time. It pulls the sleep forward, essentially.
Over time, not immediately. Think of this. I tell people to think of it like a vitamin. Like, you take vitamin C, you don't expect you're going to feel, rejuvenated right away. But if you use the light box in the morning, the melatonin consistently in the evening, you try to maintain a consistent schedule, you will pull your circadian rhythm. It'll be easier to fall asleep at night and wake up in the morning.
One jump start on this,
Yep.
if you have your late summer vacation, is to go on a camping trip.
Yeah. Yes. Very few people would have this problem if we did away with electricity, which is not going to happen anytime soon. They're watching this on a screen. They may be watching this right now, Con.
But they have the amber on right
yeah,
now.
Yeah. Use the blue light blocking software right now before you go on any farther. Okay, moving on. So we've talked about people having trouble falling asleep. Let's move on to people who are too sleepy. So Con, here is your next pilot.
For transatlantic flight is that we take naps.
We should encourage each other to take naps if you can cover for each other.
So that's an option. It improves alertness. It improves neurobiological functioning. People who don't take naps on transatlantic flights are more likely to have difficulty landing the plane.
And we have a colleague, and Con has a friend who is a member of the National Transportation Safety Board, whose main effort is to work to combat fatigue-related accidents, which affects transportation industries, trucking, railroad, air traffic controllers. All of these critical safety-related aspects of our lives. Not to mention residents, nurses, paramedics, firefighters, police officers.
It's a hard cultural change to say that during your duty time you should be taking a nap.
Yeah.
It's so hard that our Department of Transportation secretary at one point, a decade or so ago, said that we will never rest until we keep these air traffic controllers awake at night. And actually what he should have been saying is that we will rest and the air traffic controllers should take naps. Obviously they need their duty controlled during that time period.
Yeah.
So, and this is actually recommended for people doing night shift work in medicine, which is to take strategic naps to improve your alertness and neurobiological function when you awaken.
And so I will be during the intersession last year, I did a sleep resiliency training for the third years, and I hope to do that again next year. It was a lot of fun. So let's talk about most common reason why people are too tired and sleepy. I bet if you spend a couple of moments thinking about it, the answer will come to you. It is the inadequate volume or timing of sleep. So this is just the fact that we don't get as much sleep as we used to. And I put in there the timing of sleep just to remind us to again think about our body's circadian rhythm. When does our body most want to fall asleep? Let's try to sleep when our body wants us to fall asleep. If that's not possible because of our employment, school, whatever, then we should use the light box and the melatonin to move our circadian rhythms to where it is more possible for us to sleep and get refreshing sleep. Second most common cause of people I see who have excessive daytime sleepiness is sleep disorder breathing. And then third is narcolepsy and related disorders, and we'll get to all of those now. So we're going to talk about sleep disorder breathing. There's a very good reason why many of the leaders of our field have been pulmonologists, because many of the conditions that we've specialized in over the last half century have been related to sleep disorder breathing. We're going to talk about all of these different aspects of sleep disorder breathing, and they often sometimes the terms are used interchangeably, which is unfortunate because they often indicate very different problems. And we'll just start with obstructive sleep apnea. So obstructive sleep apnea is the collapse of the upper airway during sleep. It's associated with obesity, increased neck circumference. It has significant consequences: cardiovascular risk, myocardial infarction, stroke, death, motor vehicle accidents. It is a mechanical problem of airway collapse, so it requires a mechanical solution. And we have a couple pictures of this coming up, but CPAP stands for continuous positive airway pressure therapy. There's a few other positive airway pressure therapies as well. Oral appliances that you get from a dentist that help hold the mandible forward, as well as upper airway surgery. So here's a picture of what is happening with obstructive sleep apnea, which is that the collapse often happens with the collapse of the base of the tongue, and most profound usually when we're supine, because gravity is having an effect on the mandible and tissues of the neck. Other thoughts to add here, Dr. Iber?
Well, just, there are some common conditions that aggravate this. Most obvious is gaining weight, because airway gets smaller. The second is the use of alcohol, which relaxes the upper airway. And then third are nasopharyngeal conditions, which are common, like allergic rhinitis and colds. These are things that can make this problem transiently much worse. And then finally, it has a substantial positional effect. As Mike mentioned, it's a little more common because of gravity.
Yeah.
So being supine is a particular aggravation to worsening of this problem.
So this is what CPAP looks like. It acts as a pneumatic splint. It takes room air, no added oxygen, pressurizes it, and delivers it through a mask that usually just goes over the nose, although this one goes over the nose and mouth, and just acts as a pneumatic splint to keep the back of the airway open. Here's a couple examples of what a dental appliance looks like. They often look like athletic mouth guards that just help hold the jaw forward by just holding the teeth forward. There are, as I mentioned before, there are upper airway surgeries that are either remove tissue from the base of the tongue, the palate. There is a hypoglossal nerve stimulator therapy, which is essentially a pacemaker for the tongue that moves the tongue forward. Moving on to central sleep apnea. So the name central is that there's a failure of the central controller in the brainstem to adequately regulate breathing. And we're going to talk about two different types of central sleep apnea. They're often used interchangeably, but they're very different processes, one of which is opioid induced central apneas, and the other which is Cheyne-Stokes periodic breathing. So if you think about opioids, it's worthwhile to just remind ourselves of the respiratory groups, the dorsal respiratory groups, the ventral respiratory groups, which is this complicated system in the medulla and the lower pons that helps generate appropriate amounts of inspiration and expiration. The master pacemaker for this is the pre-Botzinger complex, and it appears to be that the pre-Botzinger complex is the region of which opioids works on to essentially cause an arrhythmia of respiration. Any other ways that you would describe that, Dr. Iber?
Well, I think it poisons regular rhythm generation. So the pattern is not just pauses in breathing, but the pauses are often irregular.
Yeah.
And we'll distinguish this from Cheyne-Stokes breathing. And you can even see it in the absence of apneas. If you give narcotics, the breathing pattern becomes a little bit more irregular before this pattern occurs. So it appears to be central rhythm generator poison, essentially.
Yeah, this does look probably more regular than it usually is when you're looking at a sleep study. But you'll see normal breathing, and then you'll see all of a sudden just an absent, just like you almost just missed a heartbeat and you're looking at an EKG rhythm. This is different from What's the treatment for this? The treatment is to remove the opioids, um, which raises the question of how much of a consequence was this central apnea in the first place. But that's a discussion for another time. So Cheyne-Stokes periodic breathing looks very different. This is a much wider view we're looking at. That bar there indicates 80 seconds. Before we were looking at only about a 30-second page. And this is related to a circulation delay. And what I mean by that is that normally the amount of time it takes to pump blood from the pulmonary bed to your medulla is 15, yeah, go ahead.
Total cycle length from your finger to your finger, essentially going through the entire circulatory system is around 21 seconds. But half of that is half of that plus a delay related to our devices. Yeah. So about 15 seconds. Okay. To go essentially from the lung to the place where we measure it. Most often we measure the oxygen at our finger. So
right. So if for some reason you are not ventilating adequately, and we'll just use oxygen as opposed to carbon dioxide as an example here. But if for whatever reason your lungs are not picking up enough oxygen, there is a delay between for that information to get up to your brainstem to tell you to do something about it. Right. Right. So if you have any process that delays that circulation time, it could be a diastolic problem, systolic problem, valvular problem,
right ventricular problem.
Right ventricular problem. Anything that leads to a delay can ultimately lead to this Cheyne-Stokes periodic breathing through loop gain. How do you explain loop gain, Con?
Well, actually, when we talked about narcotics, what we didn't mention is that narcotics actually slow ventilation, and so the carbon dioxide level is going up. So it causes some degree of hypercapnia and hypercapnic respiratory failure. Opioids do. Yep. Cheyne-Stokes actually causes hyperventilation. The carbon dioxide level is low, and if you'll re-show the Cheyne-Stokes pattern there, what's actually happening is we overbreathe. You can see a lot of breathing going on in that area.
This is all too much breathing.
Too much breathing. The carbon dioxide level goes to the point that anybody's central rhythm generator would shut off. Right. This same pattern happens at high altitude, only it's a faster pattern because circulation is faster. So we see overbreathing and a lowering of CO2 with periodic breathing pattern when you're skiing at Breckenridge. On the night that you are catching up on your rest, you may have periodic breathing like this, but it'll be a much faster pattern because we don't have circulation delays. The circulation delay, the feedback loop, causes this periodic pattern in heart failure. It's aggravated by pulmonary congestion, so both of these contribute to the problem. You're more likely to have it if you have an elevated wedge pressure in addition to pulmonary congestion, in addition to having circulation time. So, and I want to reiterate the point, it's anything that slows circulation. It can be a valvular problem. It can be a valvular insufficiency problem. It can be a stenotic problem. It can be right ventricular, left ventricular.
Arrhythmia.
It can be a slow heart rate.
Right.
Anything that would slow the blood flow will cause this problem.
Yeah. And here's the diverse etiologies. And so how do you take care of this? Well, to state the obvious, the best thing you should do is just treat the underlying cause of the circulation delay. If you fix the heart disease, this usually gets better.
If you transplant a person, then they don't have it anymore. If you improve their cardiac function, they may get improved. They may get improvement.
And you'll see this in patients with severe heart failure in the hospital.
About 20% of people will have it awake. So if you're very observant, and we don't look at respiratory rate carefully, you can do two things when you're seeing the patient. One is to watch their breathing and divert them into reading or something so they aren't thinking about it. Yep. And you'll see a periodic pattern in 20% of the people who also have it at night. The other thing you can do is have them lie down and fall asleep. They're often sleep deprived. And they will develop the pattern in front of you. But you have to be observant for a couple of minutes of watching to see this happen.
All right. Okay, moving on to hypoventilation. So let me give you my definition of hypoventilation, Con, and you can let me know how I did. So we need to distinguish hypoventilation from sleep apnea, both obstructive sleep apnea and central sleep apnea. Hypoventilation is the way I think about it is a state dependent, meaning during this is not just intermittent episodes of either decreases in breathing or cessation in breathing, but a state impairment in gas exchange. So there's a failure to adequately blow off carbon dioxide primarily, and at the same time then you end up with hypoxemia. Before we get into the can't breathe and won't breathe, how else would you describe and define hypoventilation?
Yeah, sort of a self-descriptive, isn't it, in a way, because it means low ventilation relative to the needs. And so the definition is often defined by PCO2, the carbon dioxide in the blood. You can have low oxygen, and you can have and at the time you're having hyperventilation. So although hypoventilation causes the oxygen to go down because it replaces oxygen in the alveolus and prevents oxygen from getting into the blood, there are other reasons why we have hypoxemia. Also, hypoventilation, as we know, can occur during the day. So if you give a patient a narcotic during the day, they will have hypoventilation during the day and hypoxemia. So low ventilation resulting in an increased carbon dioxide, which kicks oxygen out of the alveolus and prevents oxygen from getting into the body.
Okay, so and hypoventilation can be divided up into two categories of can't breathe and won't breathe. So I put my definitions. How do you describe the difference between can't breathe and won't breathe hypoventilation?
So think of the person sitting in front of us. The can't breathe person tells you that they're short of breath. They are trying to breathe. Often they have a fast respiratory rate. They might even use the muscles that we use only when we run. They use accessory muscles. So they're in distress.
You can see it. You can
see it.
You can.
And they will tell you they're having difficulty. The won't breathe people are the people, for instance, given a narcotic. And in which case they'll be looking at us, they'll be purple. If we measure their carbon dioxide level, it's very high. Are you doing it right now?
No, but they don't let you get Dr. Iber has shown me these, and you can put an oximetry on them often. You'll see the hypoxemia.
Yeah.
And it goes down, and I mean, how low can you see it without them being distressed? We're talking about the won't breathers.
Certainly, you can. The same thing will also depress hypoxic drives. They often, in the process of not breathing, have hypoxemia and hypercapnia and don't know it. And this is not very common. Certainly, most of what we see in clinical medicine are the lung conditions that cause hypoventilation, and so. But we do see it occasionally. We see it in patients with mixed edema, severe restrictive and obstructive lung disease where people have adapted to the high CO2 and they're used to it. And then, of course, the looming problem is the excessive use of narcotics.
But I remember seeing patients with you where one of the things you'll do is you'll just lie them down, put an oximeter on them. The oximeter will start dropping. They're clearly hypoventilating. And you just ask how they're doing, and they're... I'm fine. Those are the won't breathers.
We've mentioned this, and one thing we haven't touched on that's not very common is congenital hypoventilation syndrome.
We're gonna get there. We're gonna get there.
I'll hold on.
Okay, so let's give a couple of examples of can't breathe. So this is a mechanical problem. These are my examples here. Neuromuscular disease. That's a patient there with ALS, Lou Gehrig's disease. Which often results in hypoventilation. Scoliosis, which just impairs the ability for adequate mechanical ventilation, as well as morbid obesity, which particularly is a problem during REM sleep because of the loss of the accessory muscles of respiration and just the overall weight on the chest that makes ventilatory excursions difficult. Anything to add to that?
No, just in terms of common ALS and some of these neuromuscular diseases are often identifiable and not quite as common. Obesity is very common.
Yeah.
And asthma is very common. And COPD are very common. So those would be two. The lung conditions can do the same thing. A severe obstructive or restrictive lung disease will cause the same problem.
Okay. And this is a... let's go back. This is a hypnogram, full night, of what we're looking at here. So up here are the states of sleep people are in, and you'll notice they have incredible difficulty staying asleep because they're constantly waking up throughout the course of the night. And then when they get to that red equals REM state of sleep, when they're in their state of skeletal muscle paralysis, you see their oximetry drop rather profoundly. At the same time, their transcutaneous carbon dioxide measurements start going up rather precipitously. And so that, and it happens again here later during REM sleep. And then, okay, and here we are talking about this. This is what Dr. Iber was just mentioning. This is talking about the patients who have a impairment at the level of the brainstem, interfering with their ability to generate adequate respiratory ventilatory signal. Opioids being the most obvious example. And this is, we should point out that this is separate from the opioid central apnea that we talked about before, right? I mean, they go hand in hand sometimes, but
you can have hypoventilation without any central apneas.
Right.
So it's just important to remember that.
Yep. And then this condition, do you want to talk a little bit about congenital central hypoventilation syndrome now?
FOXP2B gene, phenylalanine repeats, as I remember, alanine repeats, and the syndrome occurs often and very early. So if the kids have lots of repeats, then they will have a more severe disease and will present in infancy, often with life-threatening events. Some patients with less severe genetic load will not present until adolescence or even adulthood occasionally with hypoventilation. So it's associated with other abnormalities in the neurologic system, other risk factors, including gut problems and ocular problems, and so there are additional problems associated with this, but it's a life-threatening problem. It's what used to be called Undine's curse, which is the absence of the ability to breathe normally during sleep, and so sleep becomes, and survival can sometimes be mutually exclusive. So these kids sometimes have to undergo airway management, as you can see here, very early on, tracheostomies in severe cases, and then be supported in some other method later on.
Okay. Moving on to out of sleep disorder breathing and getting into narcolepsy and other conditions of intrinsic CNS hypersomnia. So these individuals get enough sleep, they get the right timing of sleep, their breathing is okay, but they're still sleepy. Narcolepsy is a syndrome that you can pick up just by history. We do sleep studies to diagnose it, but really a good history can identify almost all cases of narcolepsy. They have sleepiness during the day, but they also have they also have other things going on, including cataplexy. Cataplexy is the sudden intrusion of paralysis, that REM paralysis we were talking about, that intrudes into wakefulness, and I have a couple examples of this in a minute. In addition to that, they have these other clinical phenomena, including sleep-related hallucinations, so right as they're falling asleep, hypnagogic, or right as they're waking up, hypnopompic hallucinations. And the way I think about this is that their dream mentation is just persisting into wakefulness. So we were talking about the various times where different parts of your brain can be awake and asleep at the same time. Your brainstem and reticular activating system is starting to wake up, but different regions of your cortex are still asleep. Sleep paralysis, which is the persistence of REM atonia or REM paralysis into wakefulness. So if you've ever woken up from a dream and you can't scream or you can't move, oftentimes with still the feeling of a frightening dream mentation nearby, that is sleep paralysis. People with narcolepsy have those very frequently, and it can be quite disrupting. It can be quite distressing. And then an important piece to notice here is that people with narcolepsy, in addition to being sleepy all day long, describe fragmented nighttime sleep. So they're caught in this state, this constant state where they can't fully wake up and yet they can't fully fall back asleep. I describe it as being stuck in a revolving door between wake and sleep. And if you just talk to a patient, usually you can kind of figure that out. So we're going to talk about, I have a couple of videos of cataplexy here. So it's an absolutely fascinating condition. You do need to be aware of it when you see it to know it, though. Patients will describe sudden and unmistakable weakness that occurs with emotional stimuli, usually laughter, usually finding something funny or making somebody else laugh, telling a joke and making somebody else laugh, a football player who was a great athlete, and he would get it right before he was about ready to catch a ball. He would suddenly get weak, um, and it's due to this loss of this neurotransmitter orexin, which we'll get into in a moment, which is failing to keep REM sleep where it's supposed to and keep wakefulness where it's supposed to. So you get this sudden intrusion of this paralysis that normally happens to us when we're in REM sleep is starting to intrude during wakefulness. The examples I'm going to show you are rather profound. They can be subtle. They can be just involving the face, and sometimes they result in a complete collapse. But here's two examples. This is a girl with narcolepsy and cataplexy here, and this is her sister, and her sister is tickling her.
Oh, really?
Yeah, and her sister is tickling her, and when she tickles her, she sets off the cataplexy. So if you don't know what you're looking at, you could easily miss this. But you'll see this kind of sudden intrusion of weakness, and then when it's over, it also goes away very quickly too. So
try, sweetheart.
her sister's tickling her, and then she just collapses down, and and she just kind of these
Go on, your
sudden
turn to tickle
intrusions of
Libby,
weakness.
Matilda.
And then she snaps out of it, and then she tickles her sister. There's a lot of there's a lot of animal canine models of this. So this is a dog model. This is a lot of canines have this, and so you'll see the dog getting this. Playing and having fun with the other dog, and then gets excited. And then it gets excited, and then collapses.
Oh, that's perfect.
And he's not asleep. They're going to say he's asleep here, but he's not. He's wide awake, and he's trying to move. That's his. You can see his diaphragm. He's not asleep. And it can take. It feels like for an eternity.
Homer!
And then he snaps out of it.
Hi, baby.
Yeah.
Calm down. I know.
And it happens every time he gets excited. And
So mellow, you know that, right?
and so it's still there a little, comes back, and then all of a sudden he's going to hop up.
Homer!
And
There we go.
and he snaps out of it again. And he
Right back.
goes right back to playing.
This is not.
Isn't that something?
Yeah.
Yeah. Any other cataplexy
Well,
stories?
narcolepsy is not a very common disease, and
Yeah.
because its presentation is unusual and intermittent, we often miss this condition for
Yeah.
quite some time, and yet it's profoundly disabling for people who are trying to perform.
Yeah.
Obviously, you can't be a football player and become weak when the ball is coming to you. So, and there's a lot of other performance and safety issues. So, it can be quite distressing, and sometimes people mute their emotional responses because they're afraid of
Sure.
engaging in something that might result in the activation.
They don't have funny friends. They don't.
Yeah.
They avoid funny people. They don't go to funny movies. So this is just a description. So this is let's see, a coronal section. This is the lateral hypothalamus. This is the region where the normal orexin neurons are, and they innervate diffuse regions of the cortex. And it mainly serves to stabilize. Orexin serves for us who don't have narcolepsy to stabilize the transition of sleep. So you wake up and you stay awake, and you fall asleep and you stay asleep until it's time for you to come out. And if you don't have that switch keeping you there, you'll have this intrusion of different aspects of sleep into wakefulness. You'll have the cataplexy. You'll have the hallucinations. You'll have the paralysis the sleep paralysis that persists as you're waking up. It's thought to be due to an autoimmune mediated destruction, although we still don't know that for sure. And it's this instability sleep that explains all the symptoms that we talked about. What is the diagnosis of this? I think it's really important that this is a situation where you just need to talk to the patient. A lot of people are suffering from sleepiness. A lot of people are suffering from a narcolepsy level of sleepiness where they can just collapse and fall asleep suddenly, but don't have narcolepsy. You can get this amount of sleepiness just with sleep deprivation, untreated sleep apnea, severe circadian misalignment. That being said, what we do is we tell them for 2 to 3 weeks to put on a little Fitbit wristwatch-like device that has an accelerometer that picks up movement. We tell them to sleep as much as possible. This is done mainly to get to the bottom to make sure they're getting an adequate amount of sleep. Then we do an overnight sleep study, making sure they don't have an other sleep problem. You can pick up little cues and clues that they might have narcolepsy because of the fragmentation of their REM. They sometimes have REM quite early throughout the course of the night. They have a lot of sleep fragmentation, as we talked about. And then you keep them around the next day after they sleep in, and then you do a series of naps. And you see how long it takes for them to fall asleep. That's called the multiple sleep latency test. And if they fall asleep on average over 45 naps of less than 8 minutes a time, and they have REM sleep during those naps, at least 2 of those naps, then we call it narcolepsy. But just to emphasize, though, you can diagnose, if you know what the syndrome is, you can diagnose narcolepsy with a great degree of confidence just by talking to somebody. Treatment. So you got to first and foremost is just make sure they're getting an adequate amount of sleep. Strategic napping is often just as helpful, if not more helpful, than stimulants. But we do use stimulant medications. We use methylphenidate. We use amphetamine-based stimulants. We also use newer agents like modafinil or armodafinil. For the patients who have cataplexy, and cataplexy is often the most profound symptom and causes the most dysfunction. What you want to do is you want to suppress REM sleep. You want to suppress REM sleep during wakefulness. And interestingly enough, antidepressants, the serotonergic antidepressants, really suppress REM sleep. And so tricyclics, venlafaxine, these agents are quite effective at suppressing cataplexy. And then interestingly, sodium oxybate is, for all practical purposes, I think of it as an anesthetic. It promotes slow wave activity. Because, as we talked about before, these individuals' brains, when they go to bed at night, they're constantly waking up. They're unable to get consolidated sleep. If you give them sodium oxybate, which essentially anesthetizes them into sleep for several hours, they also have to get up a couple hours later and take another dose. When they wake up the next morning, they feel refreshed. They're not as sleepy, and they have less cataplexy. It costs $10,000-$12,000 a month, Con.
Yeah.
There's a concern for diversion, and so we don't prescribe it that much. I've had I would prescribe it in the appropriate circumstances, but usually with proper management, we don't need to go there.
So just to comment,
Yeah.
you mentioned we use venlafaxine for suppressing REM sleep during wakefulness, and I think what Mike was saying really is the REM phenomenon of inhibition of the alpha motor neurons.
Yep.
So the paralysis, because the dog that you saw was receiving and processing information, just was not able to activate its muscles. So that's what a person experiences, which can be very distressing, which is they're unable to maintain motor activity even though they're awake.
Yep. All right. Now, there's a whole category, which we're not going to go into great detail of. Let's say you don't have narcolepsy and you don't have sleep apnea, and you seem to get a decent amount of sleep and you're still too sleepy. Then you fall into this category of idiopathic hypersomnias. And to be honest, we really don't have a great handle of what these conditions are. They almost are certainly as a combination of circadian misalignment. They're people who have long sleep requirements. Different people have varying susceptibility to sleep deprivation and circadian disruption. We tend to treat them like they have narcolepsy with the stimulant-based medications. In general, the therapies don't work particularly well. One I would add in here, this is just my experience over the last year, is that they're sometimes aggressively treating these people for depression if they have a mood disorder sometimes help, even though the main feature of their mood wasn't necessarily, they didn't think of it as, they didn't think that their sleepiness was caused by a mood problem. Any other thoughts on idiopathic hypersomnia, Scott?
No.
All right. Now, let's move on. So we've talked about people who can't fall asleep. We've talked about people who are too sleepy. Now we're going to talk about parasomnias. I think the main purpose here of the rest of this talk is just to help you be familiar with these conditions when you see them in clinic. And these are not unusual. Kids have a tremendous number of sleepwalking type events. REM parasomnias are quite more common as we get older, and we divide parasomnias, which essentially means abnormal behaviors emanating either during sleep or out of sleep, depending upon the state of sleep that they came from, either non-REM sleep, REM sleep, and then I'm including one case of a nocturnal seizure, which can look like a sleep disorder. So non-REM parasomnias here are best thought of or non-REM parasomnias here, I lost my cursor there, are best thought of as a disorder of arousal. So there you are, you're in deep slow wave sleep. You wake up in the sense that enough of your brain wakes up to look around, start interacting with the environment, but your brain doesn't fully wake up and you do inappropriate behaviors, which can include just confusional arousals. If you get up and ambulate, then all of a sudden we call you a sleepwalker. That's the only real difference between a confusional arousal and a sleepwalker. And then sleep terrors, which occur usually in children, almost always in children, pre-adolescent children, who wake up screaming. They are unconsolable. They are terrifying for the parents. The child themselves, they're quite benign for, other than the sleep deprivation they're experiencing that usually got them to that point. And in the morning, the kids are just absolutely, completely oblivious that this whole thing happened. Yet the parent was quite distressed. And we've had cases where people call paramedics because they just cannot get their kids to snap out of what my neighbor described her child as being as if possessed by a demon. This is just a short confusional arousal. This is a video from Hennepin County Medical Center. They use a bell to awaken someone out of slow wave sleep. You'll see that they just have a couple of moments. He has a couple of moments where he's confused and he's going to tear off all 32 of his glued.
Oh, wow. Hey. How you doing? Good.
Oh dear.
Huh?
Looks like you got them all.
So that was just a short confusional arousal. Sometimes these events can last much longer. I'm just going to mute it there for a minute, but this is a gentleman who has these events that occur throughout the course of the night, usually not long after he's fallen asleep. They're prolonged events of nonsensical verbalization, driving family crazy, otherwise perfectly normal individual, but just having these profound confusional arousals. The trick here is to either increase the sleep intake so that there's less sleep pressure, decrease the sleep arousal, so you want to treat sleep disordered breathing if that's going on. You want to treat other underlying sleep problems, restless leg syndrome if it's there, circadian misalignment. You want to minimize the use of sedative hypnotic medications.
Sort of conceptually, it's a sloppy sleep switch, if you will.
Yeah.
So that the brain doesn't fully awaken, or does it stay asleep? And so part of the brain is carrying out an activity, the other part may not be aware of what's going on, and the more loss of consciousness there is, the less memory there is for any event that might have occurred.
So you want to reverse conditions that promote the sleep drive, sleep deprivation, sleeping pills, alcohol, reverse conditions that fragment sleep, such as sleep apnea, and just environment like noise, right? Noise will do this. This is why college is the perfect storm for these, right? Between the sleep deprivation alcohol, drug use, noise. It's amazing. We don't hear of more cases of non-REM parasomnias in college. So moving.
I'm just going to
Yeah,
say,
please.
many of the things we've talked about so far do have a genetic load. That means
Yep.
that they're more likely. Insomnia would be an example of that. Parasomnias is one of those where there's a tendency for this to occur in families
Yep.
who've had this problem. Just so part of our family history becomes very important in sleep disorders.
Okay, so we're now past non-REM parasomnias. We're going to talk a little bit about REM parasomnias. We're going to talk about REM sleep behavior disorder, and this is a cat who has had lesion experiments done that have looked at trying to understand which regions of the brain control REM sleep, and in particular the REM paralysis of REM sleep. So this was a series of cat experiments performed by Jouvet, a French neuroscientist in the 50s and 60s, who discovered that REM sleep paralysis is related to a series of neurotransmitters in the pons. I'm going to start the volume a little low here to start.
This remarkable film shows a cat in the middle of a night's sleep. Now, believe it or not, the cat is still asleep, but because some of its nerve pathways have been cut, it's acting out its dreams. Normally, when we dream, we're effectively paralyzed from the neck down. But that paralysis has been bypassed in this cat. Its brain shows all the signs of REM sleep, but its muscle activities suggest an exciting dream life chasing flies and mice. If our muscles weren't paralyzed, we too would probably act out our dreams in this way. Perhaps it's fortunate for our partners that we don't.
So, flash forward a few years. 1982 was the first patient that came in and saw Dr. Schenk at Hennepin County Medical Center, who was describing vigorous dream enactment behavior. A sleep study was performed, and because of some excellent technicians, it was discovered that the patient was having these behaviors not during wakefulness, but the patient was otherwise in REM sleep and acting out their dreams. And so this is REM sleep behavior disorder. These are some of the first patients ever discovered and reported.
Branch of medicine concerned with unusual sleep behaviors. Before we learn more about this condition called the rapid eye movement sleep behavior disorder, let me ask you, the viewer, how you would react upon hearing that a man was regularly punching and kicking his wife at night in bed while dreaming that he was being attacked and fighting to save his life. Suppose you are a physician and a patient reports that he has tied himself by a rope to the bedpost every night for 8 years to keep him from leaping out of bed and becoming injured during violent nightmares. And what if other patients mention that they usually retire at night to a sleeping bag or to a padded waterbed in order to protect themselves and bed partners from their wild, dream-enacting behaviors? What explanations come to mind to account for such bizarre nocturnal events? As it turns out, there is a medical cause and a simple and safe medical treatment for this type of striking, dangerous sleep problem. Since 1982, for the past 5 years, during the course of routine clinical practice as physicians, we have evaluated 30 patients afflicted with the rapid eye movement sleep behavior disorder. This condition has received official recognition by the Association of Sleep Disorder Centers. These 30 patients, usually very calm and pleasant middle-aged or older men without psychiatric disorder, presented for help on account of violent dream-enacting behaviors during sleep, which resulted in numerous injuries to themselves and their spouses for up to 20 years before their sleep problem was understood and proper treatment initiated. Their injuries included bone fractures, lacerations requiring stitches, and deep bruises. Many had been previously misdiagnosed by their physicians to have a psychiatric disturbance or epilepsy, and at times some received extensive therapy for these presumed disorders.
So, Con, you were at Hennepin when these patients first started coming in. I mean, this is a fascinating condition. People are struggling with it. They often don't know where to turn. A lot of family members, primary care providers wouldn't even know where to start with someone who's thrashing, punching, and kicking and hurting themselves at night. I think just being aware that this condition exists, it's not uncommon, right? I mean, conservatively, this is 0.5% of the population. So 25,000 people in the state of Minnesota, 35 million people worldwide. If you look at an elderly cohort, it's 4%, 5%, 6%, somewhere in there. It's treatable. Not every, the first cases are always the most dramatic that you hear about. A lot of people don't have this real vigorous dream enactment. Sometimes it's a lot less profound. Kind of any thoughts of kind of seeing the discovery of this condition over the last several decades, Con?
Well, I think, one of the things in a lot of these patients is the sort of shame associated with the behavior.
Yeah.
That there's an assumed intent or something as a result of what is sometimes dangerous behavior, not just for themselves, but for their bed partners.
Yeah.
And so when, much like in epilepsy, before we understood the nature of epilepsy, there was sort of an assignment of intent that was obviously unfair. These people are not aware of carrying out these activities. All of us have dreams like this.
Yep.
And some of the consequences were substantial. Often they didn't report this. They would result in separation of relationships, at least physically, at night because of this. And so, and the other thing that's happened is that we probably have seen more of it as a result of SSRIs, which uncover this agent, this disease, and so we're seeing more of it that may be induced by medications.
So what is it exactly? So REM sleep behavior disorder, as we talked about, normally during REM sleep our muscles are paralyzed. In REM sleep, it's this neuronal switch is just not turned on appropriately. There's a failure of the REM paralysis, or turned off if you would prefer thinking of it that way. And then combined with once you're in REM sleep and you have vivid dreams without paralysis, you'll have these behaviors. So the treatments are, I think I have a slide on this later, environmental safety, get anything that can be picked up, hurled, thrown, shot, so get firearms out of the bedroom. Bed partners can sleep in separate beds, at least until this is under control. And then treatments include either low-dose clonazepam or high-dose melatonin. Just a couple of examples of severe injuries. This is a woman who went headfirst off of her bed because she was dreaming that she was on a boat that was being pushed away from shore. The gentleman on the right is a patient of mine who I just saw recently and gave me permission to use this photo. He also has CPAP, so he had his CPAP machine plugged into a power strip on the floor, and he did a head first dive out of bed, and he almost enucleated himself by putting his left orbit right over the power strip where the plug from the CPAP was going in. He almost enucleated himself, had a retinal detachment, still doesn't have very good vision in that left eye.
This patient on the left, actually I was walking downtown in Minneapolis and saw her, and she has cataplexy during the day.
So narcolepsy.
She had narcolepsy as a cause for this problem.
Yep.
And so when she saw me, there was such surprise that she collapsed in the walkway.
Yeah.
So this can occur as a result of progressive neurodegenerative disease. It can occur in narcolepsy, and it can be induced by medications. So the other important thing with this is to understand the nature of how this has occurred.
If it is idiopathic, meaning not associated with narcolepsy, not clearly associated with medication, it's fairly clear that this is part of alpha-synuclein neurodegeneration. Alpha-synuclein neurodegeneration is the pathology that sets us up for Parkinson's disease, multiple system atrophy, dementia with Lewy bodies. This was Mark and Carlos's data from Hennepin County Medical Center, but the Montreal group, the Barcelona group, a lot of different centers across the world have helped confirm that if you follow these patients long enough, what you see is the development of a neurodegenerative syndrome. What is happening is that the degeneration is affecting our nerves, the neurons in the pons first, or very early on in the disease process. Other neurons that are affected here are enteric neurons. So these patients often are constipated years in advance, and they often have trouble smelling. They have hyposmia because of the degeneration is affecting their olfactory bulb. So if you have those, if you have dream enactment, constipation, you can't smell, you're at very high risk of ultimately developing a neurodegenerative condition. Those of us who study these conditions are very thankful that this condition is there, because it allows us to help predict those who are going to go on to neurodegenerative disorders and hopefully intervene. And we're developing clinical multi-center trials to do neuroprotective therapy, hopefully to help provide a cure for Parkinson's disease and related conditions. Just as I mentioned before, environmental safety, high-dose melatonin, low-dose clonazepam. Comment on nightmares, which nearly all of us will experience from time to time, occur when the brain does not fully awaken from REM sleep. Like patients with narcolepsy, then we can wake up with a feeling of paralysis, often with dream mentation intruding into wakefulness. This is a famous painting from the Dutch painter Fuseli. The patient is clearly atonic. This is a very classic experience that people describe of frozen, can't move, can't scream. This can occur to almost anyone under the right circumstances. Sleep deprivation, untreated sleep disorder, medications, beta blockers can contribute to nightmares. Any other thoughts on nightmares, Dr. Eber? Nocturnal seizures, right before we get to the end here, we are going over epilepsy at another lecture, but just to note that sometimes seizures do present just at night. As we talked about before, stage 2, N2, non-REM sleep is the state when we're most vulnerable for epileptic activity. Be suspicious of seizures, even if the EEG is normal, in anyone who is having recurrent, abnormal, and stereotyped behaviors. And here is a patient, a 29-year-old individual who is having these recurrent events. I'm going to turn the volume down because it gets quite loud, between 20 to 30 times a night. My understanding is that this individual had well-controlled seizure disorders during the day. Well, he had seizures, but they were Okay, so I'm just gonna pause it. I'm gonna mute it there, and we're gonna talk over the top of it. If you just look at the timestamp, you'll see throughout the course of the night the exact same behaviors: rolls over, prone, pelvic thrusting, screaming. He is unable to describe these events the next day. Had previously had EEG monitoring done before, did not see seizure activity, so it had previously been assumed that this wasn't seizure activity, but this is a deep frontal lobe seizure. EEG, just a reminder, only really gives us a peek inside the cortex for about 1 centimeter or so, but there's deep sulci and folds of cortex that you can have seizures emanating for and then not see these behaviors. So he's doing the same thing here about every 20-30 minutes throughout the course of the night. This was an individual who responded extremely well to nighttime Tegretol. There are some conditions of nocturnal frontal lobe epilepsy that are familial.
So explain to us the physiology of why it's the same repetitive behavior and why these occur more often in non-REM sleep.
2 reasons. Because it's an aberrant firing of a specific group of neurons. So if you fire off the same circuit, you're going to get the same behavior. Just like when people will have temporal lobe seizures, they may get the very same olfactory hallucination or sense of deja vu. And then in terms of why they happen they tend to happen during non-REM sleep. During non-REM sleep, the development of slow waves, which is the same time that synaptic pruning and that lymphatic clearance is happening, there's these synchronization of neuronal activity as the brain is starting to become more and more synchronized as you go deeper and deeper into sleep. And what is seizures other than synchronized brain activity? So if you start to predispose the brain for synchronized activity, if it's predisposed for seizures, you're going to start having seizures. But that kind of covers everything we wanted to cover. I like to show this video. Many people have their own dog who has oops, saved it. Many people have their own dog who has dream enactment. Con, have you ever had a dog with dream enactment?
Yeah.
Yeah.
If you look carefully, they may not do this. You can see them chasing a rabbit.
A little later, yeah.
A little later. But they'll do more just the, you'll see the paws moving, and this is pretty dramatic. It must have been on something SSRI.
Yeah.
Trazodone, maybe.
Maybe. But yeah, a lot of the common breeds will do this. This is a failure of REM paralysis. I had a veterinarian in my clinic one time I was talking about, and he said, "Oh yeah, all the common breeds, the golden retrievers, the Labradors, the Labrador retrievers, they'll do this sort of behavior, and it's
So we know dogs run, and so he will maybe repeat this on a different night. But again, going back to the previous case, what was specific about that seizure was the same motor activity coming from the same area of the brain, the same circuit replaying each time. And so that makes the difference between what looked like violent behavior in RBD and in seizures. The difference is the stereotypical repeating.
So just in conclusion, I hope, thank you for sticking with us for a long course. There's a lot to go over. Hopefully you found some of this that could be helpful for your own lives, for your patients. I hope you recognize that sleep is just inherently fascinating. Sleep disorders are common, debilitating, under-recognized, and reversible. They represent a unique window to understand and hopefully prevent neurologic disease. That was all for sleep. Next up on volume 5 of Brain Pods will be cognitive disorders with a very special guest, Dr. Jamie Starks. Dr. Iber, thank you so much.
Thank you.
This was great. Thanks for inviting me into your home to let me do this. And for students who are interested in bumping into you, where are you, and is the clinic where we have the students rotate through?
So we have student rotations at the University Clinic,
West Bank campus,
Riverside campus. We have regular, for you, those who are interested, we have regular meetings on Thursday mornings at 7:30, review cases. Often following that, we have didactic sessions. Some of the medical students who rotate through will actually be presenting sleep topics during those 8:15 to 8:45 times, and as well as some of the fellows who rotate through. So you're welcome to come. Also, if you're interested, you can ask for a web connection, and we can connect you to the meetings.
Dr. Tom Gustafson also has medical students rotate through, as does Dr. Muna Irfan at Hennepin County Medical Center. Thank you very much. Till next time.